Hello and welcome to the Joyscape Therapy podcast. We're so happy to have you here. We hope that here you'll find a community of professionals in the field of applied behavior analysis, one that's catered towards certified behavior analysts, also referred to as BCBAs, BCABAs, speech therapists, occupational therapists, parents of children with autism, neurodivergent individuals, and in general, anyone seeking to learn more about ABA or about interacting with individuals with autism or other related diagnoses. Tune in as we dive into episodes discussing perspectives related to shaping behavior in professional and personal settings, allowing for behavioral principles related to everyday life. Our motto here is everyday behavior for everyday people. A reminder that listening to our episodes, you can earn a continued education credit. Listen here for the code words, then visit our website at www.joyscapetherapy.com/CEUS. There, you'll enter the code words and your BACB info at checkout, and then receive your certificate in 5 to 7 business days. If you love our content, please follow us on our socials at Joyscape Therapy on Facebook and Instagram. There, you'll find fun activities to facilitate play with children, creating interactive teaching opportunities, and other relatable content. New news, we will be doing a bundle for our continued education credits for kind of a Black Friday sale coming up later this month, so please stay tuned for that. I am your host, Marissa McKenzie, and today's topic is acknowledging potential impact of treatment, a trauma-informed approach in practice. So just as a heads up, this will also be a ethics continued education. So as most of you know, those ethics and supervision CEs are kind of a separate requirement within our recertification process. So if you're here for those, you're in the right place. And today we will be focusing on ethics within the context of a trauma-informed approach in practice. So we'll be looking at research conducted by Rajaraman, Austin, Gover, Cammilleri, Donnelly, and Hanley. This article is titled Toward Trauma-Informed Applications of Behavior Analysis. We'll be linking that in the show notes for reference as well. Objectives that we'll kind of be focusing on just throughout this conversation. So what is trauma-informed care? Barriers to trauma-informed care in behavior analysis, trauma-informed care in ABA, and lastly, ethical codes to consider. So let's hop right in. What is trauma-informed care? So just to kind of get it started, 60% of men and 50% of women actually experience at least one traumatic event in their lifetime. The pandemic alone is enough to consider what impact trauma has played and continues to play within our daily lives. Noticing how world events such as wars abroad, this is also an important component to having cultural awareness and sensitivity in these realms. And if you feel unsure about the information that you're reading about or seeing, nowadays we have social media, right? So we're seeing a lot of things, but that's okay to be unsure. My first advice would be just to stay informed, right? Stay informed, stay curious, and do your best to be aware. We are oftentimes focused on research, so really just relying on some of those reliable resources to get more information. Substance Abuse and Mental Health Services Administration, also referred to as SAMHSA, states that individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful. The American Psychological Association provides a definition of trauma as an emotional response to a terrible event like an accident, a rape, or even a natural disaster. Previewing and predicting. So like we mentioned, kind of the psychological trauma, exposure to events or series of events that adversely affect functioning and well-being. Trauma-informed is to know the history of past and current abuse in life of the consumer with whom one is working, and to use that understanding to design service systems that accommodate the vulnerabilities of trauma survivors and allow services to be delivered in a way that will facilitate consumer participation. To agree to something freely with the choice of relinquishing that agreement as well is something we, kind of putting assent into play, right? A lot of these things kind of coincide, right? Ethics, trauma-informed, compassionate care, assent, right? Understanding what that looks like and, giving consent to something or assent to something and freely having a choice to decide, and then also relinquishing that and kind of taking back is part of that process. So even it can be in a form of vocal or even non-vocal communication in terms of what that agreement looks like. So when we're thinking about programming and treatment in terms of assent, it goes hand in hand. So observing an individual's response to treatment is super important. A few dynamics of assent incorporated here, thinking about freedom. So is the availability of a genuine choice? Is it not the absence of coercion? So degrees of freedom depends on the choices provided or available, the setting and or the environment. Kind of going back to coercion there, it's the suppression of appetitive, so it expands their skill repertoire, right? It increased aversive control that narrows or limits their repertoire. So when using kind of a PREMAC principle and saying, for example, first do your homework, then you can play video games, you are controlling the appetitive function. Power imbalances are always something to consider in our therapeutic relationships, in our supervisory relationships, and even our, outside of career relationships, right? Just family, friends, things like that. Power dynamics can come into play and they could get a little bit tricky. So really kind of being aware of, all those things we've just discussed, freedom, the degree of freedom and coercion and that power balance, how those all kind of coincide together. The U.S. Office for Substance Abuse and Mental Health Service Administration, again, SAMHSA, provides a complete manual and resources for the use of trauma-informed care in practice. The first step is realizing the impact of trauma to others. We cannot realize something if we don't know something. So I think that kind of goes hand in hand together as well. Recognizing signs and symptoms through observations, right? When we're conducting an assessment, when we're starting out with a new client or new family, that's what we generally start out with, right? We are conducting an assessment. We're kind of trying to see and get a good idea of what we're going into. So when we think of that, we're also thinking of observing, really using just that observational learning method to get a better picture of what's happening. So when we're recognizing this in other individuals, we also might notice signs of trauma, such as, and these, of course, it's a small list here, but the list can go on. So like a lack of energy, excessive fears, questions that seem to come from nowhere, changes in sleep, eating, energy again. So what's the issue with some of these things listed? They often show up in one form or another with some of the kiddos that we work with that do have autism. So really responding, how do we do that? What is known of the individual's experience before even going into treatment planning, right? And then going outside of that and saying, throughout treatment planning, what have you learned? So another focus is that we really want to resist re-traumatization, right? So creating a safe and low stress environment is key. Sometimes people have what we call an adverse childhood experience. This will be referred to as ACE, ACE, adverse childhood experience. So this can look like an experience of trauma at a younger age that can look something like a loss of a parent, incarceration of a parent. And therefore, the ability to thrive from childhood into adulthood with this trauma should be cautioned, especially when we're talking about, a service that we provide to individuals, to humans, right? So hence the term trauma-informed care. The Center for Disease Control and Prevention in 2019 put out a study that 61% of individuals have experienced at least one ACE. And check this out. 16%, 16, have experienced 4 or more adverse childhood experiences. So let that sink in a little bit, just to give an idea of we are working with human beings and we're teaching skills, right? And oftentimes even the kiddo that we are working with and developing goals for, it extends into the family system, right? And truly understanding that. And not all families feel super comfortable disclosing this type of information, right? Like even just thinking of our own lives, it's not super comfortable to be like, yeah, let me tell you my whole life story in our first meeting. We don't usually do that, right? So keeping that in mind, and it just goes to show, think about the effects of one traumatic event, and then times that by 4, right? So development and continued access to services that harness a safe and trustworthy environment to work through that trauma and thrive from adolescence into even adulthood. I'm not sure if you've ever heard the phrase hurt people, but whichever context you've heard that in, the underlying point is that there is a thing called generational trauma, right? And it exists and it can last for decades. So sometimes trauma can be big, or I think the better word is a little more obvious. Say you have a close friend and, they're pretty open about how the divorce of their parents at a young age had affected them and how they've gone through that and worked through that. And, there's other types of trauma that sometimes people don't talk about for years, right? So really thinking about how it's maybe been passed down for a long period of time and how maybe trauma is embedded within those family systems and how hard it can be to break those cycles. Cultural considerations that kind of takes us into, again, a lot of these things will be, intertwined together. Approaches to addressing trauma pertain to also understanding cultural considerations, right? Understanding access to resources such as therapy or mental health services. That's not necessarily always going to be available to certain people, right? And how does that relate to us? Well, as human service providers, it's essential for us to understand our consumers' experiences and move forward ethically, consciously, and overall just more mindfully. So, barriers to implementing trauma-informed care, what are they? I think that, as I know in my own experience, it has just been a really great experience to acknowledge and accept that I don't know everything there is to know out there, and even within my field. So as I'm learning myself about trauma-informed care, what it looks like in practice, I think what I want to harness in any of my mentorship relationships or even in my colleague relationships, right? And having that open conversation about like, oh yeah, it is a little bit scary. It feels sometimes a little bit out of our realm. And so when we think about how we might see this with the population that we work with, the ones that stand out to me are like anxiety and fear. And Fryman, Hayes, and Wilson in a 1998 article, it was titled Why Behavior Analysts Should Study Emotion, the Example of Anxiety, a good read on the ever-evolving idea that emotion, such as anxiety or fear-based behavior, very relevantly crosses over into behavior analysis. Approaching things with philosophical doubt to challenge what is known in a professional manner, and then develop approaches that in the end can eventually facilitate growth in many ways, growth in small ways, in big ways, even if it's growth amongst your colleagues or in your small company, and kind of expand out, right? I think talking about those fears of implementing trauma-informed care, what is intimidating about it, or maybe it's not, and you just don't know anything about it. That's another thing too, right? It's not a new approach per se, but I think it's crossing over into our field, and it's great. It's any new research that is relevant and effective and has backing on it, right? Empirical research that comes with it, we have to pause and think, okay, what do we need to do differently in a very humbled manner? So as BCBAs, I do hope that we're approaching situations that require behavior change with an analytical scope. I think that's how we set ourselves apart from others in being integrative, innovative, and compassionate with our approach, right? So, having that responsibility, and although sometimes it might feel like pressure, but I think really it is, kind of a collaborative, right? And making sure that we can approach things with compassion and care. And that brings us to our first code word today, which is caring. So some barriers that we might see in implementing trauma-informed care is our hesitancy to discuss trauma due to the conceptual confusion and interpretive difficulty regarding this phenomenon. So our conceptualization of causes and evidence. The literature has failed to garner a set of widely accepted data-informed practices demonstrating improved client outcomes. So again, a new and evolving approach and concept, but very important and relevant. So having trouble categorizing trauma and precisely defining or explaining it in behavior analytical terms, we may want to focus on a functional definition of trauma and focus on the behavioral on the behavior that correlates rather than the psychological state. So really shifting that a little bit in our minds so that we understand it in a way that we're familiar with. And we tend to focus on short-term contingencies, but we have complex learning histories. How much does that history affect us? Underlying that history and making decisions based on it may be what differentiates between trauma-informed or not. Effectiveness of trauma-informed care focus on staff knowledge and perceived efficacy rather than actual outcomes. So continued research is needed. Trauma-informed care in ABA. So kind of the framework. So what would a trauma-informed framework look like in ABA? I think it's important to consider these few things, such as building in assent, avoiding programming using tactics that might trigger trauma responses, such as, but not limited to, timeout procedures, physical prompting, etc. And closely monitoring negative emotional responses. So really taking that observational piece that we discussed prior and being able to describe implications of each as it relates to goal development and implementation. Rajaraman et al. In 2022, so they focused on 4 commitments of trauma-informed care. One being acknowledge trauma and its potential impact. 2, ensure safety and trust. 3, promote choice and shared governance. And lastly, 4, emphasize skill building. So in acknowledging trauma and its impact, let's take a look first at a few essential ethical codes. And this list can go on. These are only a few that might be more relevant than some, and just kind of opening up the conversation. Minimizing risk, 215. And so this is within our BACB ethical code. 216, describe before implementation. And 301, a responsibility to clients. So describing before implementation, I thought that was an interesting one. And, looking more into it, there's a few things that I want to highlight that stood out for me. So that code specifies that before implementation, behavior analysts should describe in writing the objectives and procedures of behavior change intervention, any projected timelines, and the schedule of ongoing review. And emphasis on ongoing review. So a lot of the times what we might be used to is those 6-month reauthorization reports that we submit to insurance. But always making sure, is this communicated with the parents? Do the parents agree to this? Does the client agree to this? And are they involved within that decision-making process? They provide the information and explain the environmental conditions necessary for effective implementation, highlighting environmental conditions necessary for effective implementation of the behavior change intervention to stakeholders and client. They also provide explanations when modifying existing or introducing new behavior change interventions and obtain informed consent when appropriate. 301, our responsibility to clients, is really shifting perspective from the present environment to personal history. Stimuli paired with traumatic events may elicit responses not explained by the present environment. So like when we were talking about earlier, kind of shifting our understanding of what trauma might look like. Although we can't see it, trauma maybe have been a past event, but understanding how that's showing in the present, even though it might not be explained at that time, right? An individual may show signs of these, which is why we want to be a little more in tune with their emotional responses. We want to be observational of how they are responding to certain interventions. Trauma might be scary because we feel like it's out of our realm. In terms of treatment planning with this in mind, it isn't out of our realm, but it may require some reframing and our shift in perspective. The current environment may have some shared stimulus to a trauma-related response. An example, I begin to have an emotional response, sweaty hands, increased heart rate, watching a kid jump on a bed that's connected to a bookshelf, because as a child, I hit my head on the edge of a bookshelf at my grandparents' house, causing me to be taken to the hospital in an ambulance and getting stitches. This is a personal history that any one person, maybe even an acquaintance or colleague, might not actually know about me. So acknowledging these experiences helps to prevent re-traumatization. Observing my sweaty palms, or maybe my pacing, or my heavy breathing, or other things that can be observed, and recommending to utilize a more universal approach with assumption that each individual has experienced trauma. Understanding adaptation and coping with traumatic experiences. So we must know, one, that it has occurred. Caution to not asking questions in order to understand better. Approaching compassionately, as shame or guilt might be at play or in effect when working with caregivers, but also understanding this is a responsibility to gain a better understanding of this. And we can do it with compassion, and also we can do it across time, but I think that avoiding it altogether could really prevent us from having that trauma-informed approach, right? Really asking some of those questions. And, the family always has a decision not to answer, but you doing your due diligence to ask those harder questions, or maybe ones you're personally not comfortable with, so that we understand, is there trauma, right? So in safety and trust, we are focusing on Ethical Code 209 involving clients and stakeholders. So Rajaraman et al. Puts an emphasis that on as much as we ensure the physical, emotional safety, as much as we ensure the physical safety, emotional safety should also be prioritized. Observing and monitoring, again, a client's emotional response matters. Trust promotes emotional safety. Just like in any of our relationships that we might have, even outside of work, right? I'm going to put more trust in someone that I feel safe with. I might disclose more to a friend that I feel can hold space for some of those emotions, right? So pairing can help facilitate trust, but also recognize that repeated use of restraint or other procedures that are more intrusive can negate that trust. The use of reinforcers to mitigate crisis situations and decrease dangerous behaviors at the start of escalation. So just some of those interventions that we hope to aim to decrease a negative response, right? Or to decrease re-traumatization, the likelihood of re-traumatization occurring. We often are thinking in perspective to clients themselves, but also take it to another level in understanding that the parents may also have had traumatic experiences. And this can have an effect on parenting styles, communication styles, with us, with other people, right? So how do we treat with these things in mind? And again, we'll emphasize this onward: awareness, compassion, rapport, and curiosity. Building an environment of safety and trust take time. These uncomfortable some of the uncomfortable households that you might walk into. And uncomfortable, I just mean, some families are super welcoming and it seems like it may come a little more naturally for them, or you quote unquote vibe a little bit differently with families, right? You may have maybe a more similar approach to life or welcoming others. And, you embrace that and it helps with the rapport. You might gain rapport a little bit quicker versus some of the households that, you might not align on some of those things, or you have different cultural experiences. So when you are uncomfortable within these households where maybe the parents aren't super welcoming or, one thing or another, how do we navigate these barriers in practice? And this also pertains again to that cultural awareness. So do we completely avoid it, press on, and do our best work? Or do we have a conversation about it? And to me, when we're talking about a trauma-informed care approach, it's, again, utilizing that curiosity to ask questions. Sometimes there is a time and a place. Like I've noticed I've built rapport with a family, in the kitchen during snack, and grandma's eating snack with the client, and we're sitting at the table and things, are shared, of course, in an appropriate way, right? Of building and having sometimes that casual conversation can lead into that more trust and safety. So just because we're naming these 4 commitments, they're not in order and they're not always linear, right? But I think where we want to focus is, how do we become aware of the trauma? When we know about the trauma, are we approaching it with compassion as we're supporting the client and the family? And are we continuing throughout treatment to build rapport and to approach things with curiosity of like, oh, that intervention didn't work, and then I tried another and then it didn't work again. Why is that? What are the barriers going on here? Sometimes they just say, oh, it's not a right fit, or we, delve in a little bit differently. We shift the way we behave and see if those things help harness a better relationship, an ongoing relationship, right? So again, really even doing research, right? If you're not familiar with a certain culture, what are you doing to become more knowledgeable there? So thinking about defining safety and trust. Environmental safety is one thing. I think that comes, a little more easy. Physical, environmental safety, those things kind of stand out on their own. So is treatment structured and predictable? Can you reduce any sensory challenges within the environment? Sometimes it's bright lights, scented candles, loud, abrupt noises. And there's relational safety. Do the people around hold space for emotions and validation? This can also cross into a stylistic piece, a cultural piece of maybe people are not comfortable sharing their emotions. Or if a kid cries, maybe their parenting style is like, hey, suck it up, keep it going, right? Or are they really using kind of that more gentle parenting model where you are doing your best to leave space for that and validate? Again, just everyday challenges, not saying that one way is wrong or right, but as individuals who conduct therapy within the home, within the natural environment, oftentimes, even in schools, we deal with some of this too, where you just have different styles, different understandings of things. How we navigate it matters. Again, going back to some of these things, are we creating an environment of safety and trust? Building rapport can look like starting out with casual conversation, moving towards how to help that individual move with more mindfulness of being trauma informed, and ourselves as well. We are kind of the directors in a way of seeing all the moving pieces. How do we get them to work together? And after we get them to work together, how are we able to kind of bring ourselves out to create sustainability, right? To be able to, for the family and the client, whomever is involved in that natural supports for that kiddo, how do we keep that going without our presence? And a lot of that goes into training and understanding what is working, what isn't. Are we collaborating to shift and pivot with the child and reading some of those responses, right? Providing choice. And there's also internal safety. Does the child have regulation opportunities without fear of them being taken away, such as the use of punishment or to use as a reinforcement? Can the client unmask and be accepted? In promoting choice and shared governance, we may implement this regularly in what we call preference assessments, right? Let's take this a little bit further. Ensuring that when the opportunity arises and it's appropriate, are we opening up the opportunity for the client to actually be an active playmaker in the treatment planning by promoting choice for the client in treatment interventions? I personally have yet to implement something like this to the extent that we're really giving that choice. I mean, I have definitely worked with a kid and we've asked, right? And sometimes breaking it all down, that's a part of our role as well, right? Is breaking it down. We're not going to call it are you okay with this treatment intervention? That might not be the best way to ask that question to a 10-year-old client. But we can break it down for them so they understand. And also remembering, going back to one of the first few minutes of this presentation that it can also be non-vocal communication. Reading the response to the intervention is a way of communicating. Integrating procedures and practices that support client control, choice, and autonomy. Note that the importance of choice, just as an ascent, power dynamic, we are developing space where the client can have a shift in experience within interactions where, due to previous trauma, they may have experienced loss of power, loss of control, and building up someone and shifting their experience so that they actually have that power, have that control. How do we share this space with them? So we are balancing the scales of power, right? Power and control. And the last commitment is emphasizing skill building. Are we empowering an individual through adaptive behavior? Recovery is facilitated through relationships which promote skill development and support learning. A more trauma-informed care approach in this would be prioritizing skill-building interventions over tracking data, let's just say, on behavior only, right? If we're tracking data on a kiddo yelling or a kiddo hitting only and provide no replacement behaviors to supplement that behavior, it's an incomplete job, right? Promoting teaching gently through concurrent chains, treatment choice, next level choice making, hands-off extinction and modified extinction. These are some of the things that they mention in Rajaraman et al. And we'll reference that article in the show notes for you to follow along, but they really break down these strategies in a way that was super informative. So again, promoting teaching gently through concurrent chains, treatment choice, next level choice making, hands-off extinction, and modified escape extinction. And the second code word here that we're going to use is gentle. So this here is taken from a CEU that was taken on CEUEY, Applications of Trauma-Informed Care from Recent Research, instructed by Valerie Evans. I thought they gave this really great example, and I just wanted to share. I think it was a really relevant one. So in the first example here, we see the commitment of promoting safety by hearing out the caregivers. So a child with autism is afraid of earbuds. The caregivers and treatment team shrug this off as an eccentricity of autism and are happy to eliminate earbuds to satisfy the child. However, the behavior analyst is interested in observing the response and developing a plan. I want to pose the question to our listeners here. In this example, what are your thoughts? How would you proceed? I think expanding a little bit more, what are your thoughts on the behavior analyst wanting to continue to observe the response and even develop a treatment plan to move forward after the caregivers had mentioned, it's just a thing, like, it's all right, it's fine. Because I bring that up, I think that there's always a scale of, sometimes I wonder if we as a collective give up too easily. And I don't say give up, that might not be the best word, but that we hear the caregivers and we're like, okay, sure, let's not move forward. But I love here in this second example that chains from the first, that the BCBA decides to go a little bit further here. From the earbud example, parents push back that the treatment plan is not necessary because they have successfully avoided earbuds. The behavior analyst suggests that having a fearful reaction to stimuli may mean that the child will always have anxiety that the earbuds will appear. He suggests pairing treatment with a stimulus, such as an apron that the therapist could wear. Then, once treatment is underway, begin asking the client if she wants to work on the goal by presenting the apron. Here we have the commitment of choice and governance. And here we also see the behavior analysts going above and beyond in terms of stepping into what we all would normally, maybe, I shouldn't say all, but what we would normally kind of veer away from. I know I would, I'll admittedly say, right? Like that fearful reaction of stimuli may mean that the child will have anxiety, that the earbuds will appear. That's a wonderful perspective. And I think one that we should all learn from and pertain to practice, what we see on a day-to-day. And that might not be for every kid or every family, but in this situation with this example, what I want to point out to is earbuds. So when I think earbuds, I don't know if this is just branding that's done a good one on me, but I think of AirPods. Where do you see AirPods? Because I see AirPods everywhere. I mean, I see AirPods, when I'm driving on the freeway. I see AirPods at the airport. That's a very common one. I see it. But I also see AirPods like in the grocery store. People are grocery shopping with their earpods or with their AirPods, or they're talking on the phone, right? Or sometimes they are listening to music or maybe a podcast, hopefully the Joyscape Therapy podcast. Okay, but not to veer off too far. I think that there is some social significance to these earbuds, of course, depending on the family, the client. But if he is in middle school or high school, maybe even elementary, I don't know if kids are having, earbuds in elementary, it wouldn't surprise me. But, his exposure to the earbuds may not be significant at home per se, but if he does continue this fear and have anxiety with the presence of earbuds, this could be a problem, right? So again, I love the context that this goes into, where you're capturing what we discussed earlier of that fear and anxiety that does come into our realm, and how we choose interventions. Love the choice, right? Let's put it on an apron. Let's pair some stimuli with, okay, are you ready to work for this or ready to work on this? If not, okay, right? There is a choice. So explaining this rationale when parents are appropriately expressing their disagreement to this approach at this time. But it is our responsibility to provide a clinical explanation while also promoting choice and governance for the client. So I wanted to present this again as a good scenario where, for the most part, maybe we would have stopped attempts to intervene based off of the parent's request, but remaining objective to this situation and still being able to offer a clinical perspective to the family. Does the family have, some of our clinical insight on how this could affect, right? So we're talking about fear, anxiety, exposure to earbuds outside of the home, right? Programs created with trauma-informed care in mind. Cusp Emergence has an approach, it's called SAFE/T, safety. So the S is for system, supervision, and support. A is for assessing and documenting risks. F, functional assessment of historical variables. E, engineering and managing the environment. And T, trauma and treating behavior after trauma. It includes checklists that help guide your practice. The first checklist asks if the client can answer the statements affirmatively and includes statements for each letter. The checklist also specifies these things are revisited regularly, not just reviewed once at the beginning and then kind of forgotten about. And there's an emphasis on being a buffer protecting clients from contacting further treatment, and finding ways to build more buffers into their lives. Buffers can be regular exercise, coping strategies, good nutrition, enough sleep, mental health care, safe relationships. PFA, or SBT, was created by Dr. Greg Hanley, and these resources are also available on the website in the training in their methodology. And PFA includes a questionnaire that parents answer. They know what triggers their child and also what instigates challenging behavior and what makes it stop. So PFA stands for Practical Functional Assessment, SBT, Skills-Based Treatment. So skills-based treatment is all about shaping, meeting them where they're at, and giving them choices for if they want to participate and how. Some ethical codes to consider. So when we have ethical considerations in implementing trauma-informed care, what we're focusing on is minimizing potential risk, ensuring selection of least restrictive procedures, involving stakeholders in therapeutic decisions, and integrating client choice into interventions. Within our BACB ethics code, there's 4 core principles, those being benefit others, treat others with compassion, dignity, and respect, behave with integrity, and ensure your competence. So benefiting others. We work to maximize benefits and do no harm. So protecting the welfare and rights of clients above all others. Treating others with compassion, dignity, and respect, really just acknowledging that personal choice in service delivery is important. And I know we've discussed that a lot throughout this presentation, and it obviously is a key holder within this approach, trauma-informed. So it's important by providing clients and stakeholders with the information needed, like we saw in that example where the BCBA was kind of breaking down why he wanted to move forward in the treatment plan and offered alternatives for choices. Ensuring your competence. So remaining current on research, increasing your knowledge on best practices and advances in ABA, and participating in professional development activities. If your company has a professional development fund, my biggest recommendation is use it. Use it. Whether that be, I really love to go to conferences. I love to be in person and connect. That's not for everyone. Some people utilize their professional development fund on all CEs, you know? So also there's a lot of free CEs out there. And yeah, it's really fun to learn. And when you find something that kind of gets you going, gets you super motivated, you'll be so surprised to learn about the different resources and knowledge and communities out there that, you know, whether that be on social media or what have you, that really dig into that, you know, and I think that helps, right? That sense of community, discussion, collaboration, working through challenges, kind of in a group work mode. I really like that. And I think that we live in a world nowadays where technology is a part of our day-to-day life. And, you know, that's one of the benefits too. Ethics codes, we touched on some of these, but again, kind of expanding on that list. 105, practicing within scope of competence. 106, maintaining competence. 113, coercive and exploitative relationships. 209, involving clients and stakeholders. 211, obtaining informed consent or assent. 215, minimizing risk of behavior change interventions. 301, responsibility to clients. Expanding a little bit on the identified scope of competence. So engaging in professional activities in new areas, right? New populations, expanding on knowledge for new procedures, only after accessing and documenting appropriate study, training, supervised experience, consultation, co-treatment from professionals competent in a new area. So co-treatment is huge. I think I've talked about it before on previous episodes. I am a hands-on learner, and I do love co-treating with OTs, SLPs, because they can model. They're there to model, right? They're really showing you, like, this is what we're working on. This is how you do it. This is how I do it, right? And then, we can gain more skills within our repertoire, on our tool belt, right? And that doesn't mean we're an expert just because we observe them, and we don't want to get into practicing out of our scope there. But co-treatment, especially for ABA, because we have more hours working with the clients and the family, so really we're a bridge. And that's where I see where I've learned so much. I've worked with so many great OTs and SLPs, and even how creative they get. I think it has definitely souped up my kind of tool belt of being fun. I think I'm fun already, but sometimes it does, like, it having a new set of ideas kind of re-triggers that, oh, cool, I could use this in the environment already, or like, oh, that game can be played like that, or, especially with OT, they have a lot of like gross motor movement, fun things to implement. So that co-treating piece, I think, is super important, and that we should definitely be taking advantage of, being able to co-treat with other professionals within our, within and even outside of our field, right? In minimizing risk of behavior change interventions, so really selecting, designing, and implementing behavior change interventions, including selection and the use of consequences, with a focus on minimizing risk of harm to clients and stakeholders. Recommend implementing restrictive or punishment-based procedures only after demonstrating that desired results have not been obtained using less intrusive means, or when it is determined by an existing intervention team that the risk of harm to the client outweighs the risk associated with the behavior change intervention. So even before we go into that, if we feel like we've exhausted our tool belt, I encourage you to go into what we talked about earlier, reassess, re-ask some of those questions to see if trauma is there. Take that universal approach that is recommended, that each individual we've encountered has experienced some form of trauma, and tap into your people resources. Sometimes we forget, like, you don't just have to read the information. You just have to attend a conference to say, oh, nope, I tried all these things. And that list may be large, but I cannot expand on it enough and highlight it enough of how essential it is to make sure that you're also tapping into mentors. We should have mentors. We should have people, colleagues that we can go to, even if you're not meeting with your mentor monthly, that's fine, the frequency of how you meet. But I think it is important that before we go to some of those more restrictive interventions, when we're talking about from a perspective of trauma-informed care, are we utilizing our colleagues' knowledge as well? I think sometimes we might conduct our sessions or have our caseload, and maybe we don't have a center where we all get to go to, or an office we all get to go to. So we're working relatively separately. But that doesn't mean you can't ask your supervisor, hey, does anyone in the company have experience with this? Is anyone in the company available to consult, right? So, even when we're talking about ethics and being trauma informed, that is part of it as well. And I'm going to end on that, something I feel strongly about. And I hope that you really enjoyed this talk and were able to take away some really key points about what trauma-informed care looks like, what it is, barriers you might face, as well as what it looks like in practice, because I think that's definitely harder, right? We can read and discuss this as much as possible, but to really get an idea of, what we might face on a day-to-day, because each client is different, each individual is different, and the family dynamic there can change. But again, I hope you took a lot of information. I hope you had fun and it got your wheels turning a little bit. I hope you go out and do your own research and learn more about this and how to implement it within your practice. And again, thank you so much for joining us today on our episode with Joyscape Therapy Podcast. If you loved our content, please follow us, write us a great review. And until next time, signing out. Thanks.